Hi, everybody. Hope y'all are doing well today. Thank you so much for having me out to talk today on updates in COVID-19 as it relates to the cancer population. My name is Matthew Miller. I'm a clinical infectious disease pharmacist at the University of Colorado Hospital and have adjunct affiliations at the School of Pharmacy and School of Medicine at University of Colorado. I have nothing to disclose for today's presentation and have some objectives listed here by the end of the presentation. Hopefully, we'll be able to cover these various topics. So, a lot to unwrap with COVID-19, as probably everyone's well aware of, and maybe tired of hearing about COVID-19 at this point, 3 years down the road, but we're still here, we're still living with it, and just kind of want to give everyone here updates on management and prevention of COVID-19 among the cancer population. So just a brief background, what is COVID-19? It's a RNA virus, belongs to the coronavirus family. It's a very large family of viruses, frequently implicated with a common cold infection. There are mutant variants of the coronavirus that include SARS-CoV-1, which caused kind of the original SARS outbreak in China that really didn't see much global spread. Fortunately, we had MERS, Middle Eastern coronavirus, and then now we're in the midst of SARS-CoV-2 pandemic that has resolved, but we're still ongoing battle with infections related to SARS-CoV-2 and the variant strains of this virus that continue to cause infections syndrome known as COVID-19. How this virus replicates, so it enters the cells through the spike protein. Spike protein and the binding to the ACE2 receptor, which is expressed in many different cell lines, including lung, intestine, kidney, and blood vessels. Once the virus enters, it replicates and then releases from these cells to go on and infect other cells, and then causes inflammation and damage. Transmission of this virus, as we are probably well aware of, it's mostly through droplet, and droplet transmission occurs generally within 6 feet. The virus can be aerosolized during certain procedures and during intense coughing spells that increases its transmissibility and may extend that coverage zone. There is also surface contamination and some spread through surface and fomites. This is less common. The disease spectrum is really characterized by several different distinct stages. So there is kind of pre-symptomatic infection, and this is really why SARS-CoV-2 has become such a problem and is so much more infectious than other cold viruses, is that patients can begin spreading the virus before they know they're actually infected. And so there's this pre-symptomatic spread where you kind of have very high viral loads shedding from respiratory epithelia and then into droplets. Then patients can progress to kind of more of a mild symptomatic stage. Not everyone. A large portion of patients remain asymptomatic, which again makes it harder to kind of control this infection and from an infection prevention perspective, because you may not know you have it and you may be spreading virus to others that are more susceptible. Once patients move into mild to moderate category, most of them have kind of a self-limited course, get better, and then a select few, 10 to 20%, depending on risk factors, may progress to a more moderate to severe illness, and then a subset of those progress to critical illness. The thing to kind of note here is that the virus load usually wanes as you're moving into the more severe critical illness stages, and a lot of this is driven by the inflammatory response to the infection itself. And so there's really kind of two critical phases where we look at drug therapy for COVID-19 illness. One is kind of this early viral stage before you start getting severe symptoms from COVID-19. Most patients who progress to this more severe symptomatic illness that requires hospitalization and critical care is this kind of exaggerated host response to the infection, and that's driving a lot of the inflammatory changes and damage that's occurring. And so our drug therapies early on focus on the virus itself, and then later on in the hospitalized, maybe actually immune modulatory therapies to kind of dampen or control that exaggerated immune response to the infection. CDC and WHO have different staging categories, and this really helps in terms of who qualifies for what therapy. And those are kind of gated here. So asymptomatic, mild infection is usually patients who have kind of the typical upper respiratory signs and symptoms, can have sore throat, runny nose, sneezing, altered taste perception or loss of taste and smell is also associated with COVID-19 illness. Patients who progress to moderate may have higher fever, persistent fever, and become more ill. And then in severe infection, lower respiratory tract disease, and decrease in oxygenation, and may require supplemental oxygen or more invasive oxygen strategies. So really getting at who's at risk for illness. So there's a lot of different patient populations at risk for progression. Age is really a huge determining factor in risk, and kind of increases incrementally above the age of 50 to 65. So our older population are way more vulnerable to progression. And then obesity, other underlying comorbidities such as type 2 diabetes, asthma, other lung and heart conditions, and then our immune-compromised, immune-suppressed patient population, of which several of our cancer population, underlying malignancy, transplant, HIV, are at increased risk for disease progression and severe infection. Looking at outcomes among cancer population, this was a fairly recent publication from JAMA Oncology that looked at patients with and without cancer and at different stages, different types of cancer, solid malignancy versus hematologic malignancy. And consistently here you can see higher 30-day mortality, higher 30-day ventilation, ICU stay, and hospitalization among patients with underlying malignancy. Mostly in those who are receiving active treatment for their cancer. And a lot of this may have to do with the underlying immunosuppressive effects of some of their cancer therapies. Looking at some brief epidemiology of where we're at, I think I updated this on the 18th, and we're starting to see an increase in the number of cases here locally in Colorado, as well as the nation. And so we're kind of moving back up in our positivity rate. I think when I looked this morning, Denver County is at about a 8 to 9% positivity rate in terms of the 7-day average, and that is increasing. We haven't really seen a huge drastic increase in the number of hospitalized cases at this point in time. It's a bit early, but we are starting to see some community spread increasing with and shifting in the epi from the last Omicron variant that we are seeing, BA.2, to now the new emerging subvariant of Omicron, BA 2.1, 2.1. So you can kind of see there that this is increasing. So we're expecting, based on forecasting models, we're expecting to probably peak somewhere in the mid-June, not as high as we did in January, February, fortunately, and hopefully the hospitalizations remain less than they had during January and February surge, but we're expecting to probably see a peak somewhere in January, and then it'll trail off for the rest of the summer, and then we'll see what winter holds for us moving forward. This is just looking at circulating variants, and variants are basically mutated viral strains of COVID from the original wild-type strain. Most of the mutations center around the spike protein, which leads to changes in infectivity of these organisms, as well as transmissibility. So when we look at infectivity versus kind of the Delta variant, which was the last variant that caused very severe illness among our patients and ourselves, the Omicron variant virus is anywhere from is about 3 times more infective than Delta, the original Omicron variant, and then the subvariants of Omicron have increased in infectivity from each other. So the BA.2 is about 30 to 50% more infective than BA.1, and this new emerging strain, BA.2, 0.1, 2.1, is about 25% more infective than the BA.2. So increasing infectivity. Fortunately, Omicron is less severe than the previous Delta variant, and so we're seeing anywhere from 50 to about 80% less severe infection due to Omicron, which is helpful in alleviating some of the hospital burden, as well as some of the morbidity and mortality associated that we saw with Delta variant. As you can see here, BA.2.12.1 is increasing rather quickly. So now it's accounting for over 50% of the subvariants detected in Colorado, and these are lagging by about 1 to 2 weeks from what's actually taking place. So imagine we're well over 50% at this point across the nation and here locally. And then the other lagging measure too is with availability of at-home testing. Some of this data is probably a little bit underrepresented in terms of where we might be seeing the community circulation at, because a lot of this data is based on reported instances and positive testing from healthcare facilities and clinics. So how do we prevent this? CDC has multiple ways that we can inform our patients to take extra precautions to protect themselves, particularly our vulnerable patients, such as those living with cancer and malignancies. And so first and foremost is vaccination. Vaccine helps prevent not only symptomatic infection, but hospitalized and severe infections. Masking, particularly in moderate to high community spread of COVID-19, is really important to counsel our vulnerable patients to continue masking, particularly when they're going out into kind of crowded indoor areas where there may be poor ventilation and coming in contact with other people who may not be taking the same level of precautions. So masking is still an important counseling point. Looking this morning, actually, I think Denver County, Arapahoe, Jefferson County have moved from low to medium level of transmission. So in our vulnerable patients, we should probably be advising them to take some of those more cautious approaches, and given that there's a higher level of circulation happening in the community with this kind of increasing numbers that we're seeing. Washing hands frequently, cleaning and disinfecting surfaces, and then testing themselves, and then encouraging their care providers, their family members that live with them or that come in contact with them frequently to be testing if they have symptoms, and being able to quarantine and avoid exposing them to infection. And then updates on vaccines. So vaccines, as we know, are highly important in preventing severe infection with COVID-19. There are several different vaccines out presently. There's the Janssen or Johnson & Johnson vaccine, which is an adenovirus-based vaccine, and then there's the 2 mRNA vaccines, Moderna and Pfizer. Recently, CDC updated and said Johnson & Johnson vaccine are non-preferred due to lower effectiveness in preventing symptomatic COVID-19 and hospitalized COVID-19, and preferring the mRNA vaccines such as Pfizer or Moderna. Pfizer is approved down to 5 years of age and up. And they recently just approved booster doses for those 5 and up now, so they can get that booster dose or third dose after about 5 months from their second dose. This is particularly the schedule for patients with underlying immunocompromising conditions. So patients who have moderate to severe level of immune compromise state from either medications or underlying comorbidities should actually get 3 doses as a primary series. So they get the first dose separated by 3 to 4 weeks, then they get their second dose, and then they should get a third dose 4 weeks after the second dose to complete a primary series, and then they get their boost. And then right now we're at the 2 booster doses for this patient population. So stay in tune, CDC updates frequently, as well as FDA in terms of vaccine recommendations. These change fairly frequently, so it's always a good idea to kind of review the schedule and make sure practicing the most up-to-date recommendations for vaccine prevention of COVID-19. This is looking at effectiveness of the COVID-19 vaccination. As you can see here from this slide, the unvaccinated population, even in the Omicron surge, which was less associated with severe illness, still about 5 times higher risk of hospitalization among unvaccinated versus vaccinated cohort. And you can see here that those fully vaccinated and boosted versus just those who were unboosted, there was a pretty drastic difference between hospitalization rates. So booster did help prevent hospitalizations. Being vaccinated significantly dropped your risk of hospitalization. So these are definitely effective strategies to prevent severe disease, albeit a good reminder that patients may still develop COVID-19 infection. They're not 100% just like the flu vaccine. So people can still get infected with COVID-19, but it ameliorates their risk of developing severe symptoms and requiring hospitalization or critical care. Helpful information for, if you're like, where do I go find a vaccine? How can I get my patient a vaccine? There's a lot of good resources, vaccine.gov, CDC websites. CDPHE also has listings for how to get vaccine to patients. So lots of resources out there to help patients find a place to get their vaccine, and a lot of good information about vaccine safety and FAQs for question and answers for common patient questions related to how safe is the vaccine, how effective is the vaccine, to help relieve any kind of anxiety about receiving the COVID-19 vaccine. Prophylaxis, so we actually now have post-exposure prophylaxis for our highest risk population, those who have moderate to severe immune compromised condition, receiving active myelosuppressive chemotherapy, who are underlying heme malignancy, things like that. These patients are still vulnerable and may not mount an adequate response to the vaccine. And so now there's a monoclonal antibody preparation that has been granted emergency use authorization to further prevent the risk of COVID-19 infection and illness. Evusheld or texagevimab, silgavimab, is a combination monoclonal antibody product that has a long half-life, so it hangs out in our body for 3 to 6 months. And helps prevent the risk of COVID-19 infection. From the PROVENT trial, the risk reduction was about 77% among patients who were incompletely vaccinated or unable to mount an adequate vaccine response due to underlying immunocompromised condition. The initial dosing was a bit lower. It's now been increased due to the circulating variants maybe having reduced effectiveness from the lower dose, so they increased the dose to give patients a better response. So it's 600 milligrams total, 300 milligrams of texagevimab, 300 milligrams of silgavimab, and these are, they come in a package of 2 vials, 1 each, and the dose now is 2 packages, 2 vials each, which ends up being 3 mils of texagevimab and 3 mils of silgavimab as a IM injection into a large muscle group, preferably the gluteus. Who qualifies? So these are patients 12 and up who weigh at least 40 kgs, not infected or recently exposed to SARS-CoV-2, and who are moderately to severely immune compromised such that they may not mount an adequate vaccine response, or who could not complete a vaccine series due to adverse event hypersensitivity reactions, allergic reactions. This is not a replacement for vaccination, so patients who personally preferenced did not want to get vaccinated, this is not really a therapy to defer vaccine because of other reasons, just for medical reasons that they couldn't be adequately vaccinated or are not expected to mount an adequate response. Where to find Evusheld as well as other outpatient COVID-19 therapies. The Office of Preparedness and Response has a nice website where you can go and see all the different places in your local region that offer these therapies. CDPHE also has a website that lists other outpatient locations where patients can go and find therapy. Some of these places don't actually require a written medical orders, such that at certain locations patients may go in and kind of self sign up for treatment for some of these therapies. So how do we manage patients once they become infected? So there's a couple different outpatient therapies, and I'm going to spend most of the time talking about that and then a little bit on inpatient therapies as well. So just kind of bringing a case up. So this was a 48-year-old male who had diffuse large B-cell lymphoma on treatment with our EPOC and past medical history for HIV, maintained on antiretroviral therapy. He had completed 3 doses of his COVID-19 vaccine and then had been boosted. He was diagnosed with COVID-19 in clinic today based off of a positive PCR, well, back then, and then had his symptoms had started the day before, consistent with headache, runny nose, sore throat, and was satting 93% on room air. And so based on this, what therapies could be recommended in this patient. Have several options listed here: remdesivir, bebtelovimab, which is a new monoclonal antibody that's been authorized for treatment of mild to moderate outpatient COVID-19 illness, nirmatrelvir, ritonavir, which is Paxlovid, which is the oral antiviral, and then have listed ivermectin here. So these may be things that you run across and want to kind of work through each of these individually. So monoclonal antibodies are kind of historically been our first therapy that we've been able to offer patients on the outpatient side. And basically these mimic our own immune response to the virus. And so these are lab-derived monoclonal antibodies that bind to the viral spike protein, envelope up and clear this virus out and get rid of it. We've had multiple different preparations of monoclonal antibodies that have come and gone. So we started out with bamlanivimab, then we had bam-etazevimab, subsequently had sotrovimab and casimdevimab. Now we have bebtelovimab. Say that 5 times fast. So lots of mAbs. Right now, we only have authorization for bebtelovimab, and this is due to the current circulating viral variants that are not inactivated by the older mAb products. So they had basically lost their ability to work. The virus variants had gained resistance to these other therapies. So basically have Beb and that's it. This slide just kind of summarizes some of the evidence for the earlier mAb therapies from their phase 3 clinical trials. And as we can see, all very consistent, about 70 to 85% risk reduction in progression to hospitalization at 30 days. Number needed to treat here is about 17 to 20 patients to avoid 1 hospitalization. So pretty decent and not too bad because right now they're free, or at least we're paying for them. But they are free to patients. Patients really only generate an infusion charge for these therapies and are not, there is no cost associated with these drug therapies. They're provided, they're kind of subsidized by the federal government. When we look at the potency of these different mAbs, we see that bebtelovimab retains very potent activity against all of the current circulating viral variants, whereas a lot of our other therapies have been associated with greater than 1,000-fold increase in their neutralizing effect, so really ineffective against these current variants that we're seeing. Bebtelovimab was basically granted authorization off of phase 1, phase 2 trial evidence. There really has not been evidence comparing and suggesting clinical efficacy of bebtelovimab. It was based on in vitro lab work saying that it neutralizes the virus very effectively, and early phase 1, 2 proving that it's safe, and then associated with decrease in viral load at 7 days from baseline after infusion of bebtelovimab. Safety, very well tolerated. Infusion rate reactions was about 0.3%. Rash, itching, nausea, and vomiting less than 1% as well. So very well tolerated. It's a single IV push given over at least 30 seconds, which makes it kind of convenient, although still requires an IV infusion. Criteria for outpatient EUA therapies: positive SARS-CoV-2 test. And that could be either an at-home positive test reported to the provider or facility, or a PCR-based test done at that site. They cannot be requiring oxygen for COVID-19. They could have baseline oxygen requirements due to their underlying disease, such as they have underlying COPD or advanced lung cancer, and they're on baseline oxygen, and they're not having any increased oxygen that felt to be related to COVID-19, then they would still qualify from that perspective. They should not be hospitalized due to COVID-19, but we've actually been able to offer some patients who have been hospitalized for other reasons and then happen to screen positive on admission and have mild to moderate illness and still at high risk for progression, which is kind of the next fact there. So they should have a risk factor for progression, such as age, weight, underlying comorbidity, such as cancer history, malignancy, active receipt of immunosuppressive medications. And then for the monoclonal antibody and remdesivir, they should be within 7 days of symptom onset. These therapies really work early on. By the point of day 7, day 8, patients are either kind of getting better or already hospitalized. So this is kind of the window that you have to maybe prevent that hospitalization. If they're already at that time point and doing relatively well, these therapies are probably less likely to be effective because they're more effective early on. You've already probably mounted an immune response in most situations at that point. For the oral therapies that we'll talk about next, the approval criteria is they should be within 5 days of symptom onset. A little bit of take-home points about the monoclonals. It's like playing whack-a-mole with COVID-19 variants. These are really plug and play at this point. In vitro data supporting that they neutralize the virus, and then kind of early phase 1-2 data showing that it's safe, and then also associated with effective reductions in viral load and respiratory secretions over time. We're getting kind of EUAs granted for the next mAb when the variant shows up that shows that it's resistant to the current mAb in use. So this is kind of probably the future as it stands right now. The next variant that comes up may have resistance to bebtelovimab, and that they'll bring out the next mAb in the pipeline to say, okay, this one looks good, let's approve this one and continue using these things. What we don't really have good data on, a lot of these trials were done prior to vaccines being widely available, so we don't know the effect size of mAbs in patients who were fully vaccinated and boosted. Are the number needed to treat as low as 20, or are we looking at maybe 50 to 80 patients to prevent one hospitalization because the event rate goes down so much after adequate vaccine? So we need more information in kind of current state in patients who are adequately vaccinated, and then differentiating those who are vaccinated and immune suppressed versus non-immune suppressed to say, like, you know, how effective are these therapies, especially once they start becoming paid for products, and really where is the risk-benefit cutoff for utilizing these things and cost effectiveness. So more to come, but right now mAbs continue to be an effective option for patients and pretty convenient and well tolerated. Then we move on into direct antivirals. So we have nirmatrelvir, ritonavir, also known as Paxlovid. I'm going to say Paxlovid from now because saying nirmatrelvir, ritonavir is a mouthful as well. So Paxlovid was granted EUA in the end of December. It is a protease inhibitor, and then the ritonavir, many of you may be familiar with, used for antiretroviral therapy in the management of HIV. It's a pharmacobooster, so basically it inhibits the metabolism of the nirmatrelvir, which is actually the antiviral against the COVID or SARS-CoV-2 protease enzyme. If we weren't to give it with a booster ritonavir, then it would take too many capsules a day that patients would not be able to be compliant with. So this basically makes it so it's a more convenient dosing regimen. On the flip side, it makes it also more complicated from a drug-drug interaction standpoint because many drugs are metabolized through the liver, and ritonavir causes a lot of interaction issues. So always good, screen patients. I'll show you a website that's really helpful, that if you come up and need to screen somebody for drug-drug interactions, University of Liverpool has a really nice COVID-19 drug interaction checker, and you just plug everything in and it tells you, you know, this is contraindicated, or here's how to mitigate this interaction. So it's a really helpful tool. Dosing is 3 tablets total twice a day, and can be taken without regard to food. The duration of treatment is 5 days only. It also requires renal adjustment, so people who have kind of moderate kidney impairment at baseline should have dose adjustment. Patients who have severe kidney or hepatic impairment should not get this therapy. And then the main side effect is dyschezia, so metallic taste mostly in patients, and that seems to be more prominent soon after taking the medication. So we generally advise patients to kind of eat first, take the medication, and then hopefully their taste gets better throughout the day before they have to take it again. Evidence for Paxlovid was based on the EPIC study, and this basically found that it was associated with an 88% reduction in hospitalization at 30 days. Number needed to treat about 19. This is the University of Liverpool website. It's really nice. You just go in there and check the boxes of the COVID medication and then the concurrent medications that the patients are taking, and it gives you a real nice list of like good to go, green, yellow, use caution, red, avoid. Next up in terms of antivirals is molnupiravir, or Lagevrio. Molnupiravir was actually named after Thor's hammer. So you can kind of see the Thor hammer right there, molnupiravir. Somebody really liked Thor. So the unfortunate thing is, based on the trial data with molnupiravir, it was shown to be less effective. So about a 30% risk reduction for hospitalization at 30 days. So not as good as some of our other therapies we talked about in the kind of 80% risk reduction range. Number needed to treat 35, quite a bit higher than previous. So this therapy is actually kind of recommended as a last resort. So I can't get the patient Paxlovid because of drug interactions. I can't do a monoclonal because they can't come in for infusion. They're within the time window. I only have an option of molnupiravir at this point. So this is kind of where this therapy is really recommended by the NIH guidelines and kind of how we're employing it in clinical practice. Dosing is 4 capsules twice a day without regard to food. Fortunately, there's no dose adjustments. There's no interactions to speak of. It's very well tolerated and safe, just not as effective. The only other major point about this is in the early preclinical studies, there was mutagenicity risks, and so it should only be used in patients 18 and older. There might be bone cartilage abnormalities in adolescents, teens, young patients, and then also should not be used in pregnant and lactation due to risk to fetus and baby. So it requires contraceptive counseling for both males and females. We're kind of patiently awaiting some real-world data. The panoramic study is up to 26,000 participants. That's being predominantly run out of Oxford over in the UK, and 65 sites across Europe that are participating in this. And it's looking at real-world patients randomized to either molnupiravir, Paxlovid, or no therapy in the setting of vaccines. About 80+% of the patients enrolled in this study are vaccinated, so we'll get to really see how effective these therapies are in preventing hospitalization and resource utilization with regard to vaccine status. Then remdesivir. Some of us may be familiar with that. We've been using it in the hospital for hospitalized patients for quite some time. There was a recent trial that showed you can give it for 3 days in outpatient for high risk and associated with a significant reduction in need for hospitalization within 30 days. So very similar to monoclonals and Paxlovid, about an 80% plus risk reduction, number needed to treat of 22. And then some other therapies that people are investigating, evaluating, that are repurposed drugs. So people have looked at everything, from fluvoxamine, ivermectin, interferons, hydroxychloroquine, and kind of where we're at with some of these other therapies. So right now, fluvoxamine and inhaled budesonide actually show more heterogeneous results from trials, but in this meta-analysis, when they put everything together, they did show that maybe there is some benefit in preventing hospitalization with use of fluvoxamine or inhaled corticosteroids. These are not recommended presently due to ongoing trials, and we'll see where that goes, but may be helpful in resource-limited settings where they don't have access to any of the other available EUA products. Fluvoxamine is widely available across the world and is pretty inexpensive. Unfortunately, in some of the real-world models, the number needed to treat is anywhere from 1 to 200 with fluvoxamine, so it may be less effective. And then therapies that are actively recommended against use because of multiple studies showing no difference in terms of patient outcomes and potential for harm in some respects, particularly with hydroxychloroquine and azithromycin and heart impairment, arrhythmias, cardiac morbidity. So ivermectin, hydroxychloroquine, lopinavir, ritonavir, interferons, and nitazoxanide are not recommended and should not be prescribed just for the treatment of COVID-19. So summary of outpatient therapies, Paxlovid and bebtelovimab are really our kind of first-line go-tos. Remdesivir is a nice second option in patients who don't have bebtelovimab if supplies are short and they have an interaction with nirmatrelvir, ritonavir, Paxlovid. The main issue with remdesivir is just logistics. It's a infusion IV 3 days in a row, so it's really hard for patients who have COVID to come back to an infusion center 3 days sequentially. So this is a challenge, but when we have nothing else to offer and these are high-risk patients, a lot of times they'll come in at least for a couple of doses. and may prevent ultimate hospitalization. Again, last resort, molnupiravir. Keep in mind mutagenicity, risk, age, and contraceptive counseling for patients who are childbearing potential. There's lots of logistic considerations and makes these therapies less accessible, supply chain issues, infusions, IV, and so hopefully the next iteration of outpatient therapies will kind of improve on this logistical challenge that we have and improve supply chain and patient access. In terms of hospital management, really depends on their severity of illness in the hospital. So we have multiple therapies. We have remdesivir, we have immune modulatory therapies such as corticosteroids, and then adjunctive immune modulators to their corticosteroids such as IL-6 antagonist and JAK kinase inhibitors, and then anticoagulation as these patients are at high risk for venous thromboembolic events. So remdesivir, like we talked about, it's an antiviral, it's IV, it's a loading dose, and then generally 5 days total, up to 10 days have been studied, but there really wasn't a difference between 5 and 10 days. We mostly just use 5 days at our site. It's very safe, minimal side effects. Occasionally see some LFT increase or liver function tests go up, but usually mild and transient and resolves without treatment discontinuation. These are really best utilized in the patients who are within 7 days of symptom onset and on low flow oxygen. Really no benefit among hospitalized patients who are not on oxygen unless they're at high risk of progression and less than 7 days from their symptom onset, and then kind of treating them like you might treat the outpatients and provide the 3-day of remdesivir in that situation. Those who are on high flow, non-invasive, and invasive mechanical ventilation, there's really no benefit of remdesivir at that point. As you can kind of see from this, looking at patients not on oxygen, patients on invasive mechanical ventilation, and then those on low flow. So there's about a 97% probability that patients who are on low flow oxygen early in their course will have a lower mortality with remdesivir given. However, there's a very low chance of any improvement in patients who are on invasive or non-invasive or high flow oxygen. Corticosteroids have shown a significant mortality advantage in patients who are on supplemental oxygen. The recovery trial was like the landmark trial that showed adjunctive dexamethasone, 6 milligrams daily for up to 10 days, was associated with a significant mortality benefit in those on low flow, high flow, and invasive mechanical ventilation. IL-6 antagonists and the JAK kinase inhibitors are adjunctive to dexamethasone in patients who are kind of steroid refractory and not improving and continue to have ongoing signs of inflammatory conditions. The thing to worry about with these therapies is additional risk for infection. We have seen opportunistic infections from further kind of immune suppression among hospitalized patients with severe and critical COVID-19. Just in the sake of time, kind of clicking through those. Thrombosis, anticoagulation management recommended, so patients should get VTE prophylaxis who are hospitalized. In patients on low flow oxygen, there's actually a recommendation that could consider therapeutic anticoagulation for up to 14 days. Unless a high bleeding risk, in which case they should just do prophylaxis unless there's a contraindication to any heparin or low molecular weight heparin type product. And then patients who are admitted to the ICU on high flow should not get therapeutic anticoagulation unless there's a high suspicion or a documented clot, in which case they would get therapeutic anticoagulation. So, summary, antivirals tend to be less effective in the hospitalized patients, and then more benefit from some of the anti-inflammatory medications such as dexamethasone and some of our adjunct IL-6 and JAK kinase inhibitors. VTE prophylaxis is very important as these patients are at high risk for clot. And then also follow-up after patients discharge within 3 to 4 weeks due to potential for long COVID or post-COVID sequelae. So with that, see if anyone has any questions. And looking here, what are your thoughts on immunity from future virus strains when have had vaccine and have COVID in the last year? So kind of, if you've been vaccinated, but you got maybe one of the new variants, what's the likelihood that you have immunity from that recent infection? you do have kind of temporary immunity, and it does boost your immunity, so you're unlikely to get reinfected with that new variant, at least for about 3 months. That immunity may wane more quickly than vaccine-derived immunity, so there is potential protection. Right now, with the new subvariant of BA2, the 2.12.1, we're unclear how much previous Omicron infection translates to protection against this new emerging subvariant, so more data to come. It doesn't seem likely that given how quickly it's increasing through the population, that we're seeing a lot of inherent immunity, at least to avoid symptomatic infection, but maybe there's enough there to prevent some severe sequelae. So great. Don't see anything else. Thank you.